Dry eye is more prevalent than ever before, and the medical community has been evolving to address the needs of patients. In this episode of OCuTALK, Dr. Bryce Heffington explains what dry eye is, symptoms to look out for, different treatment options available, and new innovations being explored. Dr. Heffington?
I want to talk to you.
Not now, later.
No, now.
My name's Nick, and today we have a very special guest joining us. Please welcome Dr. Hello, everyone, and thank you for joining us for a brand new episode of OCuTALK. My name's Nick, and today we have a very special guest joining us. Everyone, please welcome Dr. Bryce Heffington. Dr. Heffington, thank you so much for joining us today.
Thanks for having me, Nick. It's great to be with you and talk a little bit about some dry eye stuff and other eye care things. So looking forward to it.
Well, absolutely. Dr. Heffington, thank you again for joining us. We know you're very busy, have a very busy schedule, so we appreciate it. So Dr. Heffington, before we get going today, do you mind maybe letting us know a little bit about your background and your specialty?
So go back a long time ago when I was a kid, probably the thing that got me inspired and encouraged and passionate about eye care was my optometrist. Whenever I was probably about 5-6 years old. We have a small family business in Springfield, Missouri. We've got 2 stores. My grandpa got it started in the mid-70s when he used to work with American Optical. Eventually, he got a hold of all the equipment. Long story short, we're still here 48 years later, 3 generations in now that we have our own manufacturing laboratory. So basically, my eye doctor as a kid kind of what got me inspired to consider the career of optometer. It wasn't my first career choice, though. First one was definitely meteorology. I wanted to be a weatherman. I thought that was awesome for what they did on TV. The science, just the elements, the high pressure systems, low pressure systems, all that. But just the relational aspect that my optometrist as a kid, Dr. Jim Sweeney, had with patients, and just getting to see them on a regular basis, kind of educate them, teach them, and just kind of share with them what got him excited about how to take care of their eyes. So that's kind of what got me excited too. Fast forward many years later, through undergrad, through everything, went down to Memphis, Southern College of Optometry, Memphis, Tennessee, started in August of 14, went to 4 years there. I actually met my wife through our church down there, High Point Church. And basically, long story short, she decided to come with me on this crazy ride back up to this family business because that was kind of the plan of me wanting to come back and work and alongside my other family members. So it's been a huge blessing. That's kind of like that 30-second, minute-long elevator speech for where I've come from and just kind of the ways that I've gotten involved in eye care, and have been doing this for, going on 5 years now, I think. So it's gone really fast.
Well, that is an amazing story, Dr. Heffington. Thank you for sharing. And by the way, you would have been a great meteorologist anyway. So,
well, thank you. Maybe it'll become a side career one day. Who knows?
You never know. Well, again, thank you for sharing with us with that. That's amazing. And so for our discussion today, Dr. Heffington, we were kind of hoping you could discuss with us a little bit about dry eye disease and the current trends in dry eye. So to start, can you explain what dry eye is to some of our viewers who may not know?
There's a lot of different definitions and variations out there, Nick, of what dry eye involves. Is it autoimmune related? Is it evaporative? But basically, it comes down to 2 schools of thought, one of which is called aqueous deficient dry eye. I see this quite a bit when it comes to patients that have certain autoimmune conditions like lupus, Sjogren's, anything like that, that kind of is a recurrent inflammatory condition of the body that kind of goes after the lacrimal glands, that decreases the amount of watery tear film that goes to the front of the eyes, which causes someone to be aqueous deficient. And the other kind, which is probably a lot more common, and apparently 86% of patients with dry eye have this condition called evaporative dry eye. And specifically what I've been studying a lot over the past several years have included the meibomian glands, these little tiny oil glands that we all have in our eyelids that when you blink, it should be, the way I like to describe it to patients is it's like squeezing warm popcorn butter oil over the front surface of the eyes, the cornea, the tear film, to give you clear vision, because it's actually part of your glasses and contact lens prescription. But sometimes if we do too much reading, computer work, books, phone, crochet, crossword, driving, I mean, really anything for that matter, where you're not blinking enough, those glands get plugged up and it becomes like a stick of hardened butter in the refrigerator. And that's kind of what comes from not having enough oil on your tear film, because you've got oil, water, and mucus, and all those layers kind of need to be in harmonious synchronization with one another. And if you have a deficiency in the outer layer, the oil layer, it's going to just allow water to run down your cheeks or evaporate too quickly in front of you, and can lead to a lot of issues. But mostly it's just the evaporative, like oil deficient, and aqueous deficient, which is like water deficient dry eye, from what I typically see.
Well, gotcha. So excellent information. So now we know that a couple of different types of dry eye. And so how are they typically distinguished in your office?
Usually we go through an extensive case history, like ask the patient a lot of questions. I've got dry eye as well too, so I'm a patient of this as well, to just kind of talk about what's giving me issues. Because a lot of people think that, is this just an age thing? Like, is it just because I'm old or something? No, we're seeing this of younger patients, middle-aged patients, and older patients, just for a variety of reasons. So we go through an extensive health history just to make sure if there's any autoimmune or chronic inflammatory recurrent concerns that could inflame those the lacrimal glands, to decrease the water supply. That's one thing we'll kind of use to eliminate, especially if there's any family history of anything like that. Another way we'll distinguish and differentiate the evaporative kind has to do with meibography, infrared imaging of the meibomian glands we do now at in our exams, as well as for patient care, but also triaging to see if there is any reduced T-butt, tear breakup tests. Like we use the sodium fluorescein. It's like this yellow staining dye that just tells us how quickly the tear film evaporates. It's like kind of pouring water onto a hot concrete surface just to see if it dissipates really quickly. So those are just a few tests I use, and some of the docs use different tests as well too. But for me, just kind of where I've gotten a little bit of my passion in, just seeing the T-butts, seeing the infrared meibography changes issues, and seeing if there's a prescription change that's a little bit undescribable. Do they work from home? Ask about lifestyle questions. Do they work on the computer a lot? Do they use their phone a lot? Have they taken up new hobbies like stitching? Because there's a lot of people over the past several years who have taken up new hobbies that it's just more than medical questions. Like, what do you do in your spare time for social enjoyment purposes? And then some people say, well, I've really gotten involved in X, Y, or Z, and I use a lot of that on my eyes every single day, 12, 14, 16 hours, whatever it is. So just really kind of listening and asking the questions, but get some scientific data to back up what we may be uncovering and listening to patients about.
Well, fantastic. I'm loving all the imagery too, the pouring water on the concrete, putting butter in the fridge. I'm loving the imagery today. So we appreciate that, Dr. Heffington. And so before the patients get into your office, what are the type of symptoms that we should probably be on the lookout for? Probably outside of our eyes kind of feeling dry, that we may have like dry eye syndrome or something like that.
So yeah, symptoms that I ask patients a lot of times are, first of all, are you aware, do you think you have some level of dry eye? Sometimes it's yes, sometimes it's no. Other thing is I'll ask are, do your eyes ever feel like that they're dry, burning, itching, stinging, scratchy, feel like they're light sensitive, feel like you have to kind of blink a lot to get things cleared up? Because a lot of people don't really put that together of, if you're blinking, it's people like cars and they like food. So the way I like to describe it is it's like a windshield wiper that's supposed to be spewing olive oil all over your windshield. And if you have to blink a lot and get the windshield wipers going again, then you maybe not having enough olive oil on the corneal surface in the tear film. So those are just a couple of the symptoms. Allergies have a lot of these similarities too. So a lot of people think that, well, I've just got allergies. Well, I've just got dry eyes. Well, I've got both. And it's really interesting to try to distinguish between the two because they sound so identical in a lot of ways, but there's some distinguishing characteristics for allergies, like the itchiness in particular, yet you can have that with dry eyes as well too, but also to recognize the time of the year. Are people doing a lot of spring cleaning? Are they doing a lot of mowing? Are they doing a lot of raking of leaves in the fall? Did their furnace just kick on and it's a drier time of the year during winter, basically? So just those are some things that not only do you ask about symptoms, but just consider the time of the year, consider their hobbies, consider their lifestyle and what they do, just to see, do they work in construction? Are they in a sterile office all day? Are they doing surgeries? Whatever it looks like.
Well, that's actually a very good answer because I don't think a lot about environmental things too. So that's actually a really good idea to always remember what you're doing. So fantastic information, Dr. Heffington. And I know you talked about it a little bit before at the beginning about your process. Once the patients come in, you ask them all these questions, and then we're doing like fluorescein dyeing and tear breakup time. So what's that office visit mainly like once they come in and once you do all of that?
So once they come in and we talk about, do you have dry eyes or not? Do we do the testing for it? Do you have it? And let's open up the discussion for that. So there's a lot of different things a lot of people have heard about, whether it's prescription dry eye drops, whether it's artificial tears or heated eye shields or specific dry eye procedures that we do here in office. And we talk about all those options just to see if something kind of piques the patient's interest a lot more. Because a lot of patients with dry eyes have done the Restasis, the Xiidra, the prescription eye drop, dry eye drops for years, and some of them feel like it works well for them, and some of them feel like it hasn't gotten anywhere for them. But some stuff we'll talk about and that we've done years ago before we started doing what we were doing recently is to open up the conversation about, yes, we'll talk about artificial tears. Yes, we'll talk about heated eye shields. It's kind of where we started from when we started doing dry eye stuff leading into what was the pandemic years, basically. Now for a little over a year now, we've done more of the BlephX and iLux 2 options, and we've actually done quite a bit of those here. That's been some newer stuff for meibomian gland expression and heating, and I made some videos on YouTube that just kind of describe this to patients. I've got like a huge TV in the exam room with a picture of one of the patients, one of the earlier patients that I've done. And I was like, hey, can I use this as just like demonstration for people so they can kind of understand what these glands are? Because now more recently, since I put this up a few months ago, all of them look at that picture and go, what is that? And is that me? Because they want to know, is something wrong with me? Is there something going on? And who is that me, basically? But it just paints a really good picture to open up the discussion to say, here's what we do. Here's an option for you. You can consider this. Just something a little bit different, and it kind of helps not have to use the eye drops, not have to use the heated eye shield or anything like that for you for potentially several years, potentially 1 year, potentially 6 months. It just kind of depends on how you respond to it. So really just opening up the conversation to say there are more options than just artificial tears, prescription dry eye drops, and heated eye shield stuff, because we've done all that, but this is kind of the newest one that's taken quite a interest in a lot of patients, as well as myself, because I've had it done twice, and it's been a significant help for me since I do a lot of charting, a lot of video editing, a lot of stuff on the computer and the phone for sure.
Absolutely. And Dr. Heffington, you actually talked about it a little bit there, and maybe when I ask this question, maybe you'll say the same thing, but I wanted to ask anyway. So when a patient comes in and they're looking at all the stuff that you're showing them and the different things that you're going through with them, is there a difference between, let's say, if a patient comes in who has like mild to moderate dry eye and a patient who comes in and has like moderate to severe dry eye? Are you doing those like in-office procedures with like your, like you said, BlephX and other treatments? What's like the difference between a patient who comes in with mild to moderate and someone who has moderate to severe dry eye? What do those typically look like?
That's a great question, Nick. We get that a lot from patients. Like, what bucket do I fall in? Am I mild, am I moderate, am I severe? Like, what are we doing with this? So first thing I like to identify is there any levels of inflammation going on with the cornea, the conjunctiva, the tissue underneath the eyelids, to see if there's any bumps, lumps, irritation, pinpoint dots of irritation, keratoconjunctiva sicca, anything like that. And if there is, then I usually start the patients on some level of mild to moderately strength steroid eye drops just to squash that inflammation, because if there's inflammation, you can't really get much done with anything, just because it's like, oftentimes when people are like, what does it mean inflammation, lumps and bumps? And I usually say like, okay, let's just say you have diabetes, or you have type 1 or type 2 diabetes, and your blood sugars or A1C are all over the map. This is what happens in inflammatory dry eye, to where your prescription can be off. Some days could be better than others. You could have certain things that may set you off, but basically we got to squash this inflammation over the course of several weeks or months, depending on how bad and how severe it is, before we look into any of these other procedures. Now, if someone comes in and is non-inflamed in a mild, moderate, or severe category, because it's all symptom subjective based, then we can talk about those other therapeutic and treatment options. But if they're inflamed, red eyes, really ticked off, we usually throw some steroid drops on to calm them down pretty quickly, assuming that's all it is. If it's something viral or bacterial, then obviously we'll throw antibiotics on. But if it's viral, we just kind of watch it and make sure it doesn't go into anything like herpes or anything shingles related or anything like that. So a little bit more of a cautious approach when there's those level of pathogens and conditions that can influence all this. So just squash inflammation. Then once the inflammation is taken care of, we open the door to see if they actually still want any of those other options, because some people just need the steroid drops, and that's great. That helps take care of a lot of the symptoms they're having, because that inflammation's gone. But even though they have a little bit of dryness, it may not be as bad as it once was, and it may work out better for them. But at least they've gained the knowledge, experience, and kind of walk through to what to know, what to expect, and how it can be better taken care of. And there's some longer term options to keep this inflammation at bay.
Well, absolutely, and fantastic information, Dr. Heffington. And so now, once the patient has been in the office, you've diagnosed them, we've done in-office procedures, What's the protocol now when you go, okay, I need you to go home and we take this, depending on, of course, every patient's different, right? So we have the, like I said, mild to moderate severe. What is like the long-term recommendations that you tell your patients when they go home with this stuff? Because it's all about compliance, right? So what do you typically recommend to your patients?
Usually if they're inflamed and we start the steroid eye drops, I'll say, let's start these drops X amount of times a day, depending on how severe it is. If it's severe, obviously you're going to be doing a lot more, but let's bring you back in like 2 to 4 weeks and see how you're doing there and modify as we go until we get you off of the drops, basically. Then once you're out of inflamed category, then we can move into therapeutic category. And this can include anything like antibiotics like Doxy. This can include the dry eye procedures we talked about, but specifically what I've been working on the dry eye, we call it our dry eye clinic here. But what I've been doing there with some of the procedures that we do for the BlephX, iLux squared and all that is we'll do the procedure on one day, whether it's the same day the patient comes in, if they're not inflamed, or if we need to bring them back because they're going to go on vacation soon or travel for work or whatever it looks like. We'll do the procedure, and then we usually like to see them back at 1 week and 1 month for tear film checks and follow-ups, because we like to see if that T-butt or the meibomian glands are starting to open up a little bit more. And the 1 week, we don't really gain too much new information. The patients may say, I don't notice any difference, or I may feel like a fraction better. And that usually holds true. But mostly it's just like a pat on the back of like, you're doing everything right. We're just kind of making sure you're moving in the right linear progression. Because a lot of times I'll tell patients, it's nice if we could get something that could go exponential for you. But most of the time, it's a linear path of how you get your tear film back. So we bring them back at 1 week, and then I'll say, let's check back in a couple of weeks at 1 month, and we'll already have that appointment scheduled just to see what things look like at 1 month. And at the 1 month mark, it's interesting, Nick, because a lot of times the glasses and contact lens prescription can change. I've seen it change about 50% of the time, because once that tear film thickens back up and actually gets a little bit healthier, it changes the density and the liquid amount that light actually has to go through. It has to go through more oil, more water, and more mucus. And it can change people's prescription a lot of time, which over the past year, having done this several hundreds of times, I've seen it change about 50% of the time. So I let patients know, look, if you're considering updating the glasses or contact lenses, we're going to reevaluate these numbers at the 1 month mark, because that's when we see things kind of stabilize a little bit more. Technically, it can take up to 5 to 8 weeks, but from what I've been seeing on a lot of patients, at that 1 month mark, keeps the patients compliant, gives them a motivation to say, okay, yeah, I probably want to update my glasses and contact lenses, but I don't want to do it prematurely because the numbers could change. So that at least kind of gives them some specific goals and milestones to meet in order to keep them compliant, as well as for us to make sure they're moving in the right direction. And we're still modifying it as we go, but those are just some basic things. And for at-home stuff, if someone wants to use the heated eye shield, if they can't afford the procedures because medical and vision insurances don't do a lot for it right now, but some people have flex spending plans. It kind of varies a lot of times. But for lubrication drops, for heated eye shields, for prescription dry eye drops or anything like that, we'll give them a set regimen. Like for the heated eye shield, if they need to use it once or twice a day, great. Do it in the morning or do it in the evening. Don't exceed that. Artificial tears, a lot of times there's no limit to them. I sometimes tell patients you can do it 100 times a day, and there's not really going to be a problem with it because there's no active substances in it. And for the dry eye prescription drops, it's a little bit different too, for just that once or twice a day dosing, just to see if they want to do that. But when you talk about the prescription dry eye drops and the procedure, the prescription dry eye drops can ring kind of this is a little bit more expensive bell. I've tried this before, hasn't really worked out for me. But some of the new dry eye procedures we're getting into and starting to kind of learn a little bit more about has opened the door for patients. Yes, it may be a little expensive, but it does do something that you may have not had done before. It may give you some new possibilities, and it should help you feel a lot better and your tears to go back to normal too. So that's just kind of the at-home versus in-office. Or if you do an in-office procedure, you're kind of under a guided structure. If you're at home, it's like, think about it like brushing your teeth. Here's what we're going to do with this just to keep things at bay and keep things clean, basically. And we talk about eyelid scrubs like OCuSoft, sustained lid scrubs, anything like that patients will pick up at the grocery store or pharmacy or anything like that, just to kind of keep the crustiness at bay, keep the Demodex at bay, anything like that.
Well, fantastic information, Dr. Heffington. And I know you talked about it a little bit earlier too, and I know we've talked about it as well earlier. But it's hard. It's hard to talk about preventative care sometimes. Sometimes things can become unavoidable. But do you recommend anything to kind of help prevent patients from getting dry eye? Is there something that you would recommend personally?
Probably the number one thing I'd recommend is make sure you get your eyes checked once a year. I mean, there's not really there are optometrists and ophthalmologists that will call themselves dry eye specialists, but really it just comes down to how much passion the doctor has about it. It comes to how much like insight and kind of their niche of what they get involved with. So the best thing I'd recommend is just making sure the patients get their eyes checked once a year at their annual eye care visit. That's what the American Optometric Association recommends. That's what we usually recommend. And usually that can open the door of conversation where someone comes in to just get their eyes checked. And they say, like, what's going on with your eyes? Any new developments? Well, yeah, actually, I have noticed a lot more light sensitivity. So that kind of opens up the door of conversation, like, well, tell me a little bit more about that. Then it can kind of lead to other things. And yeah, some people can take care of their eyes by doing some over-the-counter regimen stuff with the heated eye shield, the artificial tears, all that stuff on their own if they want to. But it kind of helps to have that healthcare professional in your corner that can see things from like the objective standpoint of like, okay, let's unpack that a little bit more. You say that you've been noticing some scratchiness. So what have you noticed recently? Has anything changed in your diet? Has anything changed environmentally? Have you tried new makeup, mascara, eyeliner products or anything like that? Let's unpack that a little bit more. Have you had any new health history events that have come down? Have you started any new medications? So really that's the biggest thing, to kind of keep things at bay, but also to have someone in your corner that's advocating for you, especially in this day and age to where there's a lot of information floating around on the internet and everywhere else that patients can find it. But really to have a passionate healthcare professional that is deeply invested in wanting to add value to someone's life, that's probably the biggest thing I'd recommend for sure.
Well, fantastic. And one other question I wanted to ask you, Dr. Heffington, and I wanted to ask you, how has the dry eye landscape changed like over the last like few years? So, and I wanted to ask you just to get your perspective on that and see what you thought about that.
Extremely fascinating for sure, Nick, because like ever since when I was in school, I mean, there was some new stuff coming out and there were some instruments and technology and procedures that were coming out to help open the meibomian glands, because that's really kind of an interest that a lot of us have, to get those oil glands open to really make sure they're promoting and producing. But having been in this several years now, it's kind of amazing how much of it has changed. A lot of instruments have been discontinued, taken off the market because they weren't effective or too expensive. Now where things are kind of going, like the iLux Square wasn't even like readily available, and it just came out towards the first generation came out towards the tail end of my schooling, so it was kind of a new thing. LipiFlow has been out for a long time, and that's been around for a while, and a lot of patients know how expensive that is, but it's nice to have a competitor in the market as well too, to keep things sharp for everyone wanting to know a little bit more. We've been investigating some new things. It's getting there. It's kind of new, but it takes IPL, intense pulsated light, plus radio frequency to combine the two instruments that a lot of derm and a lot of cosmetic clinics have been doing, that really takes care of the inflammation down deep inside the lids and the meibomian oil glands. So instead of just getting to like the surface, it goes down throughout the root of the whole thing and can technically get rid of spider web veins. These instruments are already out there, and some, I would say, more dermatology clinics are doing this, but it's something that eye care professionals are getting into a little bit more. And it does take a little bit more required compliance, such as the patients who need to come back every 2 weeks for 2 months, basically. So it's a pretty heavy time commitment that some people are like, well, I've got vacation, I got my kids traveling sports and different things, that they're great ideas. And the landscape is changing so fast. Like, it takes a lot for me to keep up with it even. And I love being able to learn about it too, because it keeps me sharp on my toes. And especially as information gets dispersed out there, patients are going to be asking us about it. And I like to be able to at least have a better understanding to help kind of disperse a little bit more directed education compared to just here's a shotgun of information to pick from, basically. So IPL and RF have been something kind of interesting. That's been kind of the new thing coming about in dry eye management. But just continuing to heat and express the meibomian glands is kind of a big thing that a lot of us are going after right now. But also being able to just contain and control the inflammation as well too. That's like the biggest thing to get started on before we do any other procedures like that too. We've looked into IPL, we've looked into all types of other stuff as well too, and they've been successful for helping taking care of patients. It's just finding the right match for what would work best for the patients that are coming in, and depending on the geography of your area, where you're practicing at, what the clientele, the patients are like, it kind of all factors into all of that to see what would best take care of them. Would heated eye shields work better for patients? We did that for a while, and it was massively beneficial for a lot of people. $25, throw it in the microwave once or twice a day, great. But then once following up with these patients years later, they lost it or forgot to do it or got exhausted with going to the microwave every day. So we needed to change and adapt things. Say, okay, we need to do things a little bit better. Let's think of this like teeth cleaning and dentistry, basically. So you get your teeth cleaned, you do stuff at home, you come to the dentist, every 6 months, 3 months, 12 months, whatever it is, to get your teeth cleaned. And that's kind of a model that we've tried to hammer home and educate patients on, of like, think of this like that. I know this is something kind of new that we're doing, but this is what we want you to think of it as. So it's interesting how much it keeps changing, and I'm excited to see what new prescription drops are going to come on the market, especially for getting rid of Demodex over the next few years, because there's some new exciting developments coming into the market on that and in the FDA approval pipeline process. So very fascinating, crazy fast how it changes.
Thank you for that information, Dr. Heffington. And before we leave today, was there anything else that you'd like to let our audience know about?
Just talk to your local eye care professionals about what's going on with anything new regarding dry eyes, blepharitis, Demodex, or anything else that you may have a certain eye condition with, because information and knowledge is changing so fast in optometry and ophthalmology. It's amazing at how much new things are being implemented and new things are being investigated, researched, and analyzed, because it causes and challenges us to become sharpened and not to become too comfortable for just spending the numbers and here's your glasses or contact lens prescription, which is still important, but it's important to consider the other medical matters that are influencing patients' vision. So probably my number one thing to hit home to the audience watching this video or anywhere else you may be: talk to your local eye care professional. Get your eyes checked once a year. Ask the questions. And even if we don't have the answers, because we don't have all the answers, like no other optometrist or ophthalmologist has all the answers, but there are wiser people than where I'm at, even that I go to, that I talk to a lot of times. But hey, I've got this question. I need some more education on this. Like, teach me a little bit more about this. Share with me what I need to be asking, what I could be doing better, because we all can be learning, because we get better as we grow and learn. And in leadership of eye care professionals, we get better as we grow and learn too. So that would be just the main thing: is talk to your local eye care professional, do your own research, and be your own patient advocate. Don't be afraid to ask the questions. And if you feel like you're being talked down to or not appreciated for asking the questions, then you might need to go somewhere else and ask questions, because we're supposed to have the heart of teachers. We're supposed to be compassionate. We're supposed to want to and desire to add value to others' lives. And it's important that patients know that and can feel and understand that, because healthcare has been hit hard over the past several years. And to really have healthcare professionals in your corner is going to be the best piece of advocating advice that I'd love to impart to anyone that watches this.
Well, that is amazing, Dr. Heffington. Everyone, that was Dr. Bryce Heffington. Again, Dr. Heffington, thank you so much for joining us today.
Thanks, Nick. Thanks for having me on. Really appreciate it.